All right. Welcome. Thank you for coming early in the morning. We always thank people for that. You're at the Center for Clinical Trials seminar series, which is the first Wednesday of every month. And this month, we're combining the seminar series with our Visiting Scholar series. And our visiting scholar for today is Joe Cappelleri, who was just talking informally with some of you, and I'm just going to give him a little more formal introduction now. But so this is the schedule. You've seen it probably on the electronic boards. It's a schedule for today, and I'm just going to tell you for those of you who only saw the announcement for this seminar. So we have this seminar, which is multivariate meta-analysis, and it goes from 8:30 to 9:30 in the newly renovated Page Hall. I've never been here actually before, so it's nice. And then at 10:30 in 4030, there's a panel discussion, and Joe is part of that, as is Evan Mayo Wilson, our organizer of the day, the Visiting Scholar Day, with Dave Shade, and Claire Snyder, Elizabeth Stewart, and Albert Wu, and they'll be talking about patient-centered outcomes. And then in 9519, we have a lunchtime seminar by Dr. Cappelleri, interpretation of patient outcomes, and that's with lunch served. And I urge those in the Center for Clinical Trials to get there early. It starts at noon. Lunch is served, as you know, in 9519. It's limited seating. It's up in the cafeteria, and we've been told we really have to, no one can sit in the aisles or on the floor or bring in chairs. The doors close when all the seats are filled. So please come early if you're in the center, certainly. And the other sponsors, the Department of Mental Health and the Center for Drug Safety and Effectiveness. So we want to make sure you all get there. And then at 2, also in 9519, we have a special seminar on mediation models and patient-reported outcomes research, also by Dr. Cappelleri. So this is Visiting Scholar Day, and we're focusing on Dr. Cappelleri's research, and this is the initial seminar. So I'd like to start by thanking the organizers of the day, Dave Shade and Evan Mayo Wilson, who've both organized. And also our co-sponsors. So the Center for Clinical Trials is a sponsor of the Visiting Scholar Day, but our co-sponsors we'd like to thank also the Center for Drug Safety and Effectiveness and the Department of Mental Health. So I hope I'm not forgetting anything. All right, so I'll go to introductions of Dr. Cappelleri. He earned his master's degree in statistics from the City University of New York, and then his PhD in psychometrics from Cornell, and his MPH in epidemiology from Harvard. And our paths probably crossed somewhere between Harvard and Tufts, where I think he went next to work with Dr. Thomas Chalmers. And we had some overlapping interests there and people that we work with. So he has a really broad swath of experience in statistics, psychometrics, and epidemiology. And I think you'll get to hear some of that over the course of the day. After Tufts, he went straight to Pfizer, where he's been for 18 years in Groton, Connecticut. And there he's the Senior Director for Statistics. He's also a Fellow of the American Statistical Association, an adjunct professor at Tufts and the University of Connecticut. So he's given lots of conference presentations, and I think most importantly, he's the author of a recently published book on patient-reported outcomes, measurement, implementation, and interpretation. So that's very important for those of us who are doing patient-centered outcomes research, and I think we have a lot to learn. I'm especially excited about the psychometrics, about which I know pretty much nothing. And so I'm looking forward to learning here. But I think it's also important to say that Dr. Cappelleri is our first visiting scholar from the drug industry. And I know we have a number of students who are interested in that pathway. And I encourage you all to come to the seminars and talk with Dr. Cappelleri informally and formally, because he's had a great experience, I think, in working with Pfizer as Director of Statistics and maintaining his academic connections and connections with the professional associations he belongs to. So without further ado, I'll turn it over to him.
Oh, thank you, Kay. Thank you. Thank you.
Watch that step.
Yes, I can see bad things happening.
Yeah.
Okay, it's wonderful to be here. My name is Joe Cappelleri. I'd like to thank Kay. When I went to apply for schools of public health, MPH in epidemiology, I applied to several schools. I got into all of them except one. Johns Hopkins. So I went elsewhere, and that's where I got to meet Dr. Chalmers, who was my mentor at Harvard, and that's how I got to meet Kay. And that was 20 plus years ago. So it turned out to be a blessing, and it's also a blessing and a privilege to be here, even though it's belated, 20 plus years hence. Oh, we have an ambitious agenda this morning. If you want to know why you're here, it's about multivariate meta-analysis, concepts and applications. I'd like to acknowledge my co-presenters, my silent co-presenters, Snedeker, Wan, and Stevens, for their contributions. Okay. Outline. Explain the concept of, oh yes, another acronym, MVMA, multivariate meta-analysis. Highlight why it can be useful. If you're like me, you learn best through examples. So you can taste the methodology. And we'll do so here by sharing a few applications. We follow with noting where the technique of multivariate meta-analysis can be implemented and give an illustration. We do so by providing some SAS code. We won't going to get too heavy into the programming, just to give you a flavor, a taste for how you may implement this in standard software. We conclude with fair and balance. Fair and balance by stating the limitations of multivariate meta-analysis. Okay. Segment 1, Introduction to Multivariate Meta-Analysis. Meta-analysis, as you may know, is the statistical aggregation of data from multiple sources. It's compiling results, treatment effects, for example, across independent studies in order to arrive at an overall estimate with a confidence interval in order to get a best representation as to what the overall effect is. When you think about meta-analysis, whether you know it or not, you're doing a meta-analysis on me right now. What are you doing? You're sizing me up, right? You get pieces of information, my gestures, my style of speech, the content, the subset. You put it all together and you form an overall impression or synopsis about the speaker. Well, that's what we do in meta-analysis. We quantify it with numbers. And there may be differences among studies, and that may modify treatment effect, and that may be useful. Maybe sicker patients benefit more from the active medicine than patients who are not as sick. Maybe one size does not fit all with respect to treatment effect. Meta-analysis is here to stay because there's an information explosion, and we need to make sense of it in a systematic way. Meta-analysis estimates an average effect even when studies have conflicting results. It can predict the effects in new studies. What if for the next study that is about to turn around the corner? There's potential for greater ability to extrapolate to the general population a more expansive set of inferences to a larger base of patients. Meta-analysis can also examine sources of heterogeneity among study results. In addition, it can be considered to be high in the evidence hierarchy. Meta-analysis of randomized controlled trials is at the top of the pyramid. It does consider those individual randomized controlled trials. It goes one step further. It characterizes them in a way that is meaningful by summarizing the best available evidence and noting where there may be differences among studies and why. Frequently, multiple outcomes are of interest, right? When we do a study, it's not just on one outcome, it's on a series of outcomes. And there may be more than one primary outcome. There could be key secondary outcomes. There are multiple outcomes or multiple treatments. Not just treatment A and B, there may be a treatment C and D as well. For multiple outcomes, there may be, for example, systolic and diastolic blood pressure. There may be multiple time points as well. So there could be multiple elements, be they treatments, outcomes, or time points. How do we handle that? Should we look at each endpoint in isolation? Each time point in isolation, as if the other time points or endpoints or outcomes didn't exist? All outcomes are measured within the same patients and therefore are usually positively correlated. Yet, we meta-analyze each endpoint separately in separate univariate meta-analyses. Endpoints coming from the same patient, analyzing them separately. Is that a good thing, or is that the best thing? As we'll learn, it may be in certain cases, and it may not be in others. Okay. Univariate meta-analysis, that is, analyzing, doing a compilation, a summarization of results on treatment effect, one outcome at a time, involves an individual assessment of different outcomes. There's the mean treatment effect of outcome 1 on the left, and on the right. It sounds so political. What would he expect the day after Election Day? And on the right, the mean treatment effect of outcome 2. That's all I know about Spanish, outcome 2. And there's a wall that we put in, this artificial wall. What we want to do, what do we want to do in this, at least in this seminar? We want to break down the wall. Okay? And draw juice and honey from one outcome informing the other outcome. The advantages of multivariate meta-analysis include the following. It utilizes information of correlated outcomes because they're coming from the same patient in the same study. It borrows information to address missing outcomes. The key term here, and for those of you who study Bayesian analysis, is borrowing strength. If a given study has a treatment effect on outcome 1, but not outcome 2, but other studies have treatment effects on outcome 2, but not outcome 1, and maybe some studies have treatment effects on both outcomes 1 and 2, we can draw strength. An outcome, even though it has missing A, can draw strength from the other outcome that may be available in that same study and in other studies. Borrowing strength, especially relevant when one of the outcomes is missing. Multivariate meta-analysis describes the multivariate relationship between endpoints. What does that mean in English? Sensitivity, specificity, right? We in epidemiology know sensitivity and specificity. It's one of our lifelines in what we do, diagnostic testing. They tend to be correlated across, if different studies have sensitivity and specificity, they may be using different thresholds to define the cut point. Sensitivity goes up, specificity goes down, and vice versa. Multivariate meta-analysis obtains pooled estimates with, in principle, better statistical properties. That is an estimate that is in expectation expected to be less biased or more unbiased, and to have greater precision, or to have a more accurate estimate of variability. It generates joint confidence interval regions. As we see here on the lower left, the joint estimate of treatment effects. We could look at it in a multivariate surface. In addition, this method can model, test, and make predictions based on the joint association of endpoints, and finally estimate some function of the pooled estimates. We have two estimates. There could be a function of those two estimates, such as may happen when we give an example later on diagnostic testing. So these are the benefits that multivariate meta-analysis may provide. There are several reasons why multivariate meta-analysis is not more common. One reason is tradition. We do it this way because that's the way it's been done. Another reason that multivariate meta-analysis hasn't gained as much momentum is the increased complexity of the multivariate approach. Parsimony is my friend. Let's leave simple enough, good enough. A third reason is the need for specialized statistical software or knowledge. If it can't be done in SAS, it can't be done. Of course, we know that's not true, but that is the justification for that argument. And finally, lack of appreciation for the consequences of ignoring correlation between endpoints. This presentation can help with that. Okay. Any comments or questions at this point? Is it pretty straightforward? Yeah. Okay. So you're with me, right? We're going to go through a nice dance together, because we're going to pick up speed, momentum, and I'm going to encourage you that we're going to follow the same dance steps during the next two presentations. And I'd just like to echo what Kay said, you're encouraged to be there this morning and this afternoon. But for the present, let's get with the present by taking a closer look at this methodology. Why do correlations matter? Well, we know that a correlation involves a mutual relationship, a connection between two or more variables. Conceptually, this means that the plausible range of values of one outcome is dependent on the other. So we see here something we know from introductory epidemiology or introductory biostatistics. Variable 1 on the horizontal axis and variable 2 on the vertical axis. We see here scatter. The observed values can span the entire range for each variable. The observed values are in two-dimensional space. Doesn't look like there's much happening there, huh? Well, that's because what we saw previously, that was uncorrelated. There's no correlation between variable 1 and variable 2. But with the red X's, we see correlation, a nice linear positive relationship between these two variables. When correlated, each variable spans the entire range. They're related and clustered here. I like this slide because this slide provides a aha moment. You know, when you have that favorite caffeine kick from your Java, and you say, now I get it. This slide did it for me. I hope it does it for you. Correlation example, distribution of body mass index and total cholesterol levels in the United States, 1988 to 1994. Let's go far top left. The probability, there's a distribution of body mass index in the U.S. population. We see here that the probability of body mass index equaling 31 is 7%. Total cholesterol comes into the picture here on the top right. Total cholesterol in the U.S. population, the probability of it being 120 is 15%, and the probability of it being 240 is 15%. When body mass index and total cholesterol are independent, there's an equal probability, therefore, of having 120 milligrams per deciliter and 240 milligrams per deciliter. Each is 15%. Now let's assume the same body mass index of 31. Bottom left. Same type of distribution as given on the top left. But now, at a given body mass index, the probability distribution of total cholesterol is changed. It goes from the top right to the bottom right. Now the probability of total cholesterol 240 given body mass index of 30 is no longer 15%, but 27%. Because these two variables, BMI and TC, are related. That's a motivating slide for why it's important to account for two outcomes simultaneously. It can change the probability of one of those outcomes happening given the other. In the world of multivariate meta-analysis, in its book of Genesis, the first two chapters are within study correlation and between study correlation. So when we think about multivariate, you're thinking about outcomes that are correlated. How can we benefit by looking at those outcomes jointly rather than separately or independently? Let's begin with the first book. The first book is on within study correlation. Indicates the association between endpoints within the study. Could have body mass index and total cholesterol within a study. What's the correlation? Arises from each individual in a study contributing data towards each endpoint. Or it could be time point if we were in the realm of time instead of outcomes. Within study correlations between endpoints are seldom reported in trials. That turns out to be a limitation, which we'll hark back to later. So what this is a call for is better reporting of what the within study correlations are between outcomes within a trial. In the second book of Genesis, as it relates to a multivariate meta-analysis, there's between study correlation. The first book is about within study, and the second book is about between study. It indicates how the true underlying endpoint summary values are related across studies. Can be induced by differences across studies such as age, changes in study characteristics, and threshold levels in diagnostic studies. Right? In epidemiology, sensitivity, specificity for a diagnostic test. The different studies can be using different cutoffs or thresholds, and therefore arriving at different pairs of sensitivity and specificity. Across studies, we would expect there to be a correlation between sensitivity and specificity, a negative correlation between the two. And that's what this third bullet says. The fourth bullet suggests that between study correlations can accurately describe the true bivariate relationship between the true log odds in the treatment group and the true log odds in the control group, or the baseline risk. Now that's a mouthful. Let me break it up for you. It could be that the treatment effect may depend on baseline risk. Perhaps in the studies that have patients with higher levels of severity of illness are more likely to benefit from treatment. What we know in the epidemiology world as effect modification. The treatment effect may be modified by some characteristic that is particular to the study. It could be the type of patients enrolled. It could be something else, some other study or patient characteristic. So the effect modification with baseline risk, which is measured as the log odds in a control group, can serve as a proxy for severity of illness. And we wish to establish the relationship between the log odds in a treatment group and the log odds in a control group to see if they're related in order to assess effect modification of the treatment effect. the log odds ratio. Using correlations in multivariate meta-analysis allows a joint synthesis of the multivariate endpoints. It accounts for any correlation between endpoints that may exist both within studies and between studies. Those are the two layers of correlation. And in doing so, encompassing the correlation allows for useful estimates of treatment effect. Here's a take-home bullet. Correlations allow a borrowing of strength across endpoints. Number one, generally leads to corrected pooled estimates and standard errors, which is a nice thing. The standard errors tend to be lower relative to those from univariate meta-analysis, especially when at least some of the endpoints are missing at random across studies. In addition, the correlations allow more narrow joint regions of distribution of effect. Multivariate meta-analysis reverts to separate univariate meta-analysis of each endpoint when all correlations are zero. Within study correlations are zero, and between study correlations are zero. And one endpoint does not borrow strength from another endpoint. That happens in the case where there is complete data. The borrowing of strength comes in when at least one of the outcomes has missing data in at least one of the studies. Okay. Here, for those of you with a quantitative bent, here's the bivariate random effects meta-analysis model. We won't go into too much detail here. I do provide references by Riley in the Journal of the Royal Statistical Society and the BMC Medical Research Methods. The take-home here is that there's a bivariate model, and when, as I noted, when all correlations are zero, one endpoint does not borrow strength from another endpoint. It's a two-layer model. It allows for random effects. It allows for the treatment effect to be different for each study, and that the distribution of those individual treatment effects hovers around a central position treatment effect, and that's what we get from the meta-analysis. So you think of a distribution, each study has a treatment effect, it's normally distributed. The center of that distribution becomes the meta-analytic or overall treatment effect, or the overall sensitivity, or the overall specificity, whatever the outcome is.
Question.
Yes, sir.
So
Ian.
for the correlation that you're talking about, is that the correlation at the level of the aggregate data within the trial, or is that the patient level?
The patient level data. It's a good question. It's about what does that correlation pertain to. It's the individual patient correlation.
So then do you need individual patient data to do this?
It definitely helps. You know you can get it. And one of the limitations of Ian is right on, and I'm going to mention it in a subsequent slide, is that what happens if those who have the individual patient data do not report it in published reports? Then we have to call, because we do need the individual patient data to get the individual study correlation. And once we have, and we can get the between study correlations once we have the rest. Yeah. So we do need the individual patient data. What this means is a press for better reporting of our meta-analytic findings. Okay, and that's a main reason why this technique hasn't been used, because we don't know. What's done is people make assumptions. Sensitivity analysis. They may know from other studies or other published reports what the correlation may be within a study, assume that value, and then go a little higher, go a little lower, and see if the results change materially. Any questions, comments, and most importantly, criticism? Any criticisms? Any intellectual skepticism here? Because I'm going to be skeptical towards the end. Okay. It's good to have a good measure of friendly, what they say, spirited discussion. Don't want it to be too spirited. Spirited enough. And that's what we're going to do here. We're going to have a spirited example. Okay. Kathy Berkey. Remember her? Yes. Yeah. Kathy Berkey was a dentist from Harvard who also has a doctorate in health policy and management, and was with us at the technology assessment group with Tom Chalmers when I was a student and when Kay was collaborating with Tom. So she has that blend between dental research. Then they got the dental content area and the health policy and management. She published this paper. Fred Mosteller was on this paper, David Hoagland, about mean improvement in probing depth between surgical and non-surgical procedures, and mean improvement in attachment level between surgical and non-surgical procedures. So the outcomes here are mean improvement in probing depth and mean improvement in attachment level. We see here there are 5 studies. Each study has a mean improvement score along with its variance. In this study, we see the covariance between those between probing depth and attachment level within each study, and the corresponding correlation within each study. Kathy Berkey had the individual patient data and therefore was able, Ian, to report the correlation and the covariance within each study between these 2 outcomes. Now, we're going to go through something that you can remember very crisply. At least that's my intention. Here are the data. Here, within study variances are much smaller than the between study variances. You can see how small the within study variances are for each of the and the between study variances. You don't see them here, but I can tell you that if you know about R-square, the proportion of total variation between studies that is genuine, that is due to real differences or heterogeneity, it's almost 70% for probing depth and almost 97% for attachment level. So here's a case where the within study variances are much, much smaller than the between study variances. There's also complete data here and only small differences between the within study variances. So not only are the within study variances smaller than the between study variances, there's not much variability between the within study variances. And when that happens, the within study correlation has little effect on estimates and standard error. Therefore, the pooled results from the univariate meta-analysis are similar to those from the bivariate meta-analysis, which incorporates the correlation between probing depth and attachment level. So here, if we did a univariate meta-analysis, we would have come up with essentially the same answer. We don't gain anything. There's complete data here. We can't borrow strength from outcomes that are missing. And because the within study variances are much smaller than the between study variances, and there's very little variability among the within study correlations. Okay? So if you know the nature, the magnitude of the within study variance of treatment effect, we have that here, and also the between study variances and their relationship to one another. And if the within study variances are much smaller than the between study variances, then we could have gotten away with less fanfare with doing a univariate meta-analysis. Here's what the results look like. This is, again, treatment for periodontal disease, surgical and non-surgical. Here are the results. On the left side, mean improvement in attachment level. On the right side, probing depth. And the results, the estimates, corresponding 95% confidence intervals for each of the studies. And what we see here at the bottom is the univariate meta-analysis result and the bivariate meta-analysis result. So, for example, the green here, where the laser beam is pointing, we can see how close the values are in terms of estimates and confidence intervals for attachment level and also for probing depth on the right side here. Because, again and again, between study variance is much larger than within study variance. Okay? This, of course, can be quantified. If you go to the papers in Riley, There are formulas. I suggest that you imbibe in your favorite beverage when reading that paper, because the algebra is not pretty. But it's all there. There's a mathematical justification for this. Right now, for the purpose of the presentation, I'm stating to you conceptually and qualitatively why the results of the univariate and the multivariate are essentially the same. Okay. Which begs the question, when could the results be different? Here's another example. Scholastic aptitude test, Gleiser and Olkin. Olkin is a professor emeritus at Stanford University, 90 years old. Liz, we had a party for him at JSM. A lot of good people turned out. 90 years old and still teaching. He taught a course at JSM, Joint Statistical Meetings, last year on meta-analysis. Here, we're in the educational realm. The outcomes are mathematics scholastic aptitude and verbal scholastic aptitude. Specifically, for each of the 7 studies, the mean standardized mathematics scholastic aptitude test score between coaching versus uncoaching. In other words, does coaching matter in terms of grade on mathematics scholastic aptitude? Similarly, does coaching matter, coach versus uncoached, for the verbal scholastic aptitude test score? Each of the 7 studies has a mean on the scholastic aptitude test score, standardized, and a corresponding variance of that mean. In addition, individual patient data allowed for there to be a covariance of these 2 aptitude test score within study, and therefore a corresponding correlation. So you can see the correlation is moderately high, ranging from 0.57 to 0.66. Now, look at these right here. We just focus on mathematics aptitude. These are the within-study variances of the treatment effect for the 7 studies. And also, we can look at the same for verbal. Here, there are large differences within the study variances, unlike what we found with the dental example, where the within-study variances across studies were quite similar. Keep that in mind. When this happens, when there's large differences between the within-study variances, that facilitates borrowing strength across endpoints and explains why the bivariate meta-analysis and the univariate meta-analysis can be somewhat different. In this case, the bivariate meta-analysis for mathematics gave an overall estimate of 0.99, whereas the univariate meta-analysis gave a higher estimate of 0.25, slightly different. With respect to verbal aptitude, the univariate and bivariate results are very similar. So they differ here only in terms of math aptitude. And that's because we have to know the yin and the yang, the within study of. We know that there's large differences between within study variances. In addition, there's a lot more variability for the mathematics scholastic results across studies than there is for the variability of the verbal scholastic aptitude scores among studies. That's why there was a difference with math, but not with verbal. So in both cases, there was large differences within the within-study variances. Okay, good to know, but not enough. And it's because the mathematics scores had more between-study variation in results that its results differed from the corresponding univariate findings. And here are the results graphically. We see a difference as noted here. This slide gives the results on each of the outcomes within each study. And we see here the corresponding estimates with confidence intervals for the univariate set and the bivariate set.
Joseph, can I
Yeah.
ask a question?
Yes.
On the periodontal example, more so than this one, but this one is, I don't even know that a meta-analysis is warranted. There's so much between study variance.
Well, let's go to that.
So it just, if you show the graph, I think it becomes obvious. So those seem so different, those studies, with both attachment level and probing depth, that I'm not sure we should even be talking about a meta-analysis. How do you justify that and jump to a multivariate meta-analysis?
Well, that's a good question. The question is, should we even be doing a meta-analysis for the periodontal data, given there is a large variation in results? Well, one reply is that a random effects model was used, so it acknowledges, at least in part, that the results could differ from study to study and incorporates that between study variability in treatment effects. Another is, it would be prudent, as I'm sure you would agree, that we want to know why there are differences in study results. So maybe in the original paper, the authors looked at differences in study results according to study characteristics or patient characteristics. We see here that the good news is that at least the mean improvement for each of the studies is an improvement. Each study had the same directionality, right? So that gives us some hope. If there was mean decrement for some studies and mean improvement for other studies, that would be more alarming. The fact that the direction of the treatment effect is on the same side is somewhat reassuring. Okay.
Well, maybe we can talk about it after you finish. I just mean, if you're going to get into the sort of multivariate analysis, when do you decide that's warranted, that it's worth it even doing a univariate analysis? And even with the subsequent data that you're showing, I mean, here with the random effects model, the smaller studies, those ones with the bigger confidence intervals, are given more weight. And so certainly on the probing depth, then I worry. Those are the more extreme values. So if at the end you could just discuss sort of the hierarchy of your decisions, like when do you get into the fancier statistics? Is it even warranted if the univariate is questionable?
Yeah. So why do even consider a bivariate? Kay's saying, why consider a bivariate? If even the univariate may be questionable, is it worthwhile to do a meta-analytic investigation on results that are maybe perceived as disparate? It could be that the sample size is smaller in some of the studies than in others. That could account for the large variability. The short answer is that we need to look more into these 5 studies in order to have a higher claim on whether a meta-analysis is warranted. So something we can go back to the original articles and form our own assessment on that.
I'm sorry, I might be reading this graph wrong. You said the directionality is the same, but attachment levels are negative and probing depths are positive?
No, yeah. What I meant, attachment level, all of them are negative. Negative is good, is improvement for attachment level.
You mean the interpretation.
Right.
Yeah, okay.
If we look at probing depth, on the other hand, all the estimates, and in fact all the confidence intervals, are positive. Positive is good for probing depth. Negative is good for attachment level. And not only are the estimates in the right direction, the entire confidence interval is in the right direction. That gives some reassurance that it may be worthwhile to consider a synthesis. as well as look at the results of the individual studies, look at the between-study variation. And in fact, in this study, this is what Dr. Dickerson was mentioning. Look at this I-squared. 68.8% for probing depth, almost 97% for attachment level. That is to say, the total variation between studies is dominated by true heterogeneity and not by chance variation. So there is justification in this comment and room to be skeptical. Okay. So it turns out in this case it doesn't matter which of the two meta-analyses we use. So this is the type of critical faculty you need to use when doing these types of analyses. Any other questions? Yes?
On the one with the SAT scores, maybe I misinterpreted what you said before, but didn't you say that if there weren't missing data, that this multivariate would not add anything? And
Yeah.
I would not think there would be missing data between these two.
Yeah. Generally, that's true. There are two ways that the addition can borrow strength. Mainly, it comes into play with missing data. It also, to a lesser extent, can come into play when there are large differences between within study variances, as there is here. But you can see that's the case here. But the results in math, 0.9 versus 0.25, it's not a big difference. It's a difference, but not a big difference. If there were missing data involved, chances are the difference would be more. Yeah, thank you for mentioning. That's a subtle point, and I'm glad you're listening. Very good question, and not just a good question, as have been all these questions. Comments? Questions? We're just warming up.
You have 10 minutes.
I got 10 minutes. I got to move on. All right. Sensitivity, specificity are measures of the accuracy of the diagnostic test. Sensitivity, specificity, we know, right? For every test, there's one pair of sensitivity and specificity. The within correlation is not relevant because they are measured in different subgroups. Remember, specificity is in the non-disease group. Sensitivity, on the other hand, is in the disease group. So we're not going to get a within-study correlation that is a non-zero because the two groups are independent within study. Between study correlation, however, is important because in this case, sensitivity and specificity are negatively correlated. To pool data from multiple studies, one approach would be combine data using standard methods for proportion, coming up with a combined estimate of sensitivity separately from a combined estimate of specificity. However, ignoring the correlation of the outcomes between studies may be inappropriate in certain instances. Here we could do a bivariate meta-analysis of sensitivity and specificity, obtain the between-study variation, do a 95% confidence interval for each outcome, and provide a confidence ellipse. We'll get into an example of that soon. We can get a receiver operating characteristic curve and find out whether sensitivity and specificity are different for different technologies. We're going to go through an example on that. And here's the example. Okay. Taken from the Journal of Clinical Epidemiology. Diagnosis of lymph node metastasis. There are three types of imaging tests: LAG, CT, MRI. Okay? Each is done with a bivariate meta-analysis, and in doing so, there's a pair of sensitivity and specificity, and also a diagnostic odds ratio. The diagnostic odds ratio is the ratio of the odds of a true positive relative to the odds of a false positive. So we want this number to be high. However, if we look at the diagnostic odds ratio and separation, we can mislead. Previous methods have focused on the diagnostic odds ratio. What we want to do here is note that using the correlation between sensitivity and specificity across studies, we know that LAG has the highest sensitivities of these 3 imaging tests. We want to compare them in terms of sensitivity and specificity. With respect to specificity, the specificity of LAG is significantly lower than that of CT and MRI. The diagnostic odds ratio, which a previous approach applied, suggests MRI is much better than others, but that can be misleading after we take into account the sensitivity and the specificity. Here's a graphical depiction of receiver operating characteristic curve, 1 minus the specificity on the horizontal axis, sensitivity on the vertical axis. For each modality, of which there are 3 imaging tests, the region contains the likely combination of the mean values. So this bivariate approach allows us to provide a confidence ellipse as to what the likely, in which the likely values of the true false positive rate and true negative rate are contained. When we do that for each of the 3 modalities, we see the confidence ellipses clearly show the difference in specificity and sensitivity of LAG compared with CT and MRI. So this is one benefit of the bivariate approach. It allows for this graphical depiction, graphing the 2 outcomes, sensitivity, specificity, simultaneously for each of the 3 modalities. Okay. MVNA software, I'm going to go through a brushstroke on this, focusing only on one of several slides. These methods can be implemented in PROC mixed, which have been used for over a decade. The methods for multivariate meta-analysis can also be used in WinBug, Stata, and R-Package. Details are here if you wish to know more. Here is an example in SAS, an abridged example of the lymph node example with 3 modalities we just covered. We're not going to go over the details. These slides are yours, so you can go to them, go to the original sources should you wish to do a multivariate meta-analysis on sensitivity, specificity, as well as other types of outcomes. Limitations of the approach are such that the dependence or ignoring the correlations are not well understood. So there's more research that needs to be in the areas. That can also be seen as a gain. There's some assumptions about normality that may not hold, and that has been criticized by Stephen Zen, sarcastically saying, multivariate meta-analysis, such pretty pictures. Problems with the within-study correlation, as Ian noted, it may not be available. And they're available only if individual patient data are obtained. In practice, this is unrealistic. Problems with within-study correlation include the following. And these are potential solutions. We can do a sensitivity analysis. We can apply a Bayesian approach to estimate what the within-study correlation would have been if it were reported. Other limitations are publication bias. Is the objective to correlate primary and secondary outcomes, and secondary outcomes are not missing at random, then this may bias both primary and secondary effects. So the question about missing data, it makes the assumption that the data are missing at random. If it's informative, if the data is not missing at random, the multivariate approach may result in bias. The borrowing of strength, but the borrowing of the wrong strength under an incorrect assumption. Okay, this is the slide you've all been waiting for, and we want to allow time for at least a couple more questions if we can. Summary, we explained the concept of multivariate meta-analysis. We highlighted why it can be useful. We discussed a few applications. We went into the world of scholastic testing, lymph nodes, and also dentistry. We know, in addition, we noted where, very briefly, how the approach can be implemented, what software is available. There's slides on how to implement the lymph node example in SAS. We stated the limitations of multivariate meta-analysis. Limitation is mainly that what we need to know is not provided, so we have to make assumptions, specifically with respect to within-study correlations. Here are the references if you wish to learn more. These references are noted throughout the presentation, and here's my contact information. Yes?
So my question is, let's say for a study you have one primary outcome and 3 secondary outcomes, and most of the examples you showed are bivariate analysis. And I guess depending on which secondary outcome you're going to combine with your primary, you may or may not get a similar estimates of the treatment effect. So it may make the treatment look even better by picking the right secondary outcome, or worse. So what is, I guess my question is more about like the steps or the decision points where, you pick the right, not pick the right outcome, but the rules to follow.
Fabulous question. We have 3 secondary outcomes, 1 primary outcome. Could it be that if we pair the right secondary outcome with the primary outcome, we can get a more favorable result on the primary outcome? That's the question, right?
Yeah.
Yeah, that I take us to Becker here, Betsy. She says, in the realm of research synthesis, the consequences of accounting for modeling dependence or ignoring it are not well understood, on which we can add, what would happen if we happen to choose the right secondary outcome or the wrong? How can that influence the primary outcome? If it does so in a substantive way, we should really question what's being done here. Okay? I would expect, and the answer to your question is that we don't have enough research at this time, which is why you can write one of the first articles on this subject. Yeah, that's a good question. And what happens if we want to consider all 4 outcomes, the 3 secondary, right? That's what you were going to say, right?
Why limit to bivariate?
Right. We don't. Did it for simplicity here.
So I guess, I'm sorry, one approach could do all different permutations or combinations of outcomes and look at the distribution of the effect estimates and see if they're all favorable, then you're more confident that
Right.
the result is
Right.
positive.
Yeah, and we would be leery, wouldn't we, if the result of the primary actually depended heavily on what secondary that primary it's paired with, right? So we can use them all in a much more advanced model, all 4 outcomes simultaneously. That would probably be the best approach. What has been documented in the literature has been the bivariate case, because sort of you got to crawl before you walk, right? Go with the bivariate, and then we advance to more than 2 outcomes. Okay? Yeah.
Have you looked at cumulative meta-analysis for multivariate?
Subject close to my heart. We were talking about the people behind cumulative meta-analysis last night over dinner. The question is, have we looked at cumulative meta-analysis in the context of a bivariate meta-analysis? The short answer is no, which is why you're going to write one of the first articles, if you so choose, on this subject. This is an emerging field. For those of you who wish to choose a dissertation topic, I'm thinking of the students, this is a good one. What is the interplay between cumulative meta-analysis and bivariate meta-analysis? My work on cumulative meta-analysis, there's repeated testing, right? There's an updating. For those of you who don't know about cumulative meta-analysis, once a new study gets published, it gets added to the results of the previous study. So now we have a new overall estimate. And then another study gets published, and then we add that to the previous sets of study results, and we get a new estimates. And then we can plot whether there's a time trend. Maybe we can see some trend over time where the estimate's getting smaller and it's gravitating to a central point in terms of, for example, odds ratio. My work has been involved, how do we adjust for the repeated testing on that? That was new at the time. Now, we're in a different realm. This in the realm of multivariate meta-analysis, and how does that interplay with cumulative? To my knowledge, no one has done research in that area. I have not seen even a paper mention that,
Yeah.
let alone in a discussion. So remember, you heard it here first. So thank you for the comment.
I
Yeah.
think that the cumulative meta-analysis, I think, is the only value of literature-based meta-analysis that still exists. I think you have to go patient-based, which is patient-level data, which is what you're taught.
Yeah.
is mostly about.
Yes, in the back.
Hi. I'm trying to figure out when you should use this tool, because so far as I can tell, it doesn't seem like it really helps with decision making to give you one final summary, right? Because you have estimates for each outcome. But then it seems like it's for when you have missing at random data that you want to compensate for. Is that what this tool
Yeah,
is
it
for?
could be useful. Let's go back to right here. Looking at that second example on When should we use this tool? If there's a series of studies when for at least one of the studies, and possibly more than one of the outcome, mean improvement in some outcome, for example, is not provided, but it is in other studies. So we could, assuming missing at random, we can use these methods as the information obtained from the non-missing outcome could be used for the missing outcome. It also comes into play when the within-study variances are different across the studies and when there's a lot of between-study variation. That happened with the mathematics aptitude score. The within-study variances across the studies were different, and also there was a lot of between-study variation in treatment effect. So
I think that goes back to Dr. Dickerson's point of, at least here, we've been trained that if there's heterogeneity, perhaps you should hesitate from doing a meta-analysis. And you're saying that this is a way to overcome that by assumption?
Well, let me say that we should, if we were to do a meta-analysis, now between study variation, they're not necessarily going to be as high as they are here. Suppose it's 40% or 50%. It's what is the ratio between study variation and within study variation. And there's a formula for this. It's in the book. So what we can do is we should look at the individual study results and then make an informed decision on whether it's worthwhile to do a univariate meta-analysis and maybe a multivariate meta-analysis, depending on layers of heterogeneity. What we mean by between study variation and within study variation, if it's very, very high, we should be skeptical. We should at least report the results of the individual studies. But what happens if it's a much more moderate clip? Then these approaches become more amenable. And also we can look at differences of why there are differences in study estimates, raise the bar up rather than just to provide one overall estimate.
So I hate to end this because it's a great discussion, but Dr. Cappelleri is here all day, and he doesn't talk again till 10:30. So you could come down and talk to him. Maybe he'll sit and have a cup of coffee with you at the Daily Grind or who knows what. So I thank you all for coming, and thank you, Dr. Cappelleri. And just to tell you all, there's a panel in W4030, so down the hall and up 2 floors, on patient-centered outcomes research. And then Dr. Cappelleri will be the only speaker at his noon seminar on the 9th floor in 95-19, and then also continuing on at 2 o'clock there as well. And I'll leave this up here in case you haven't seen it, but it should be on the electronic board as well. So
Give
thank you.
yourselves a hand. You did wonderful in participating. Active participation. Thank you.